some years of my life. Professor John Cleland is interested in cardiology, in heart failure, in telemedicine, and he will speak with us today about management of heart failure with preserved ejection fraction. Professor Cleland.
Well, thank you very much for that kind introduction. You were one of our best students, and well, thank you very much for all your contributions. I'm John Cleland. I'm Professor of Cardiology, but work within the School of Cardiovascular and Metabolic Health. So I think that it's quite appropriate that I'm speaking with you today. I'm going to talk about heart failure, but remember, heart failure is the final common pathway for many cardiovascular diseases and probably many non-cardiovascular diseases as well. So a very common and under-recognized problem. What is HEF? Well, it is a heterogeneous bunch of things. First of all, we have HFrEF. So HFpEF is not HFrEF. HFrEF is an ejection fraction less than 40%. HFpEF actually covers a multitude of sins. It used to include HFmREF. That's mildly reduced ejection fraction. There's now a sort of move to moving the boundaries for HFrEF up to 50%. My good friend Andrew Clark, who some of you may know, prefers the term HFnEF, and I reserve this for the patients with an ejection fraction between 50 and 69%. And more recently, we've discovered that there is a subset of patients who may be rather different, the patients with HFsNEF, supranormal ejection fraction. And these are people that may have things like hypertrophic cardiomyopathy, for which we now have some interesting new treatments like aficamten and mavacamten. Not that we can afford these as yet in the UK. I don't know about the Egyptian economy, but someday soon I think that we will have these treatments available for our patients. The pathophysiology of HFpEF is in some ways similar to HFrEF. There are common features like left atrial pressure, left atrial volume. They have common comorbidities like atrial fibrillation and anemia. But there are some differences, and in particular, potentially manipulating outcome by modulating heart rate might have rather different effects in HFrEF and HFpEF, so that slower heart rates seem to be beneficial in HFrEF, perhaps because they save myocardial energy. But on the other hand, slowing the heart rate may actually increase symptoms, may increase the problems for patients with HFpEF. So the diagnosis is important. We should also remember that there is considerable measurement error when we're phenotyping people by left ventricular ejection fraction. And this is another reason why I don't think we should abandon the HFmREF group too quickly. If you have an ejection fraction between 41 and 49%, we will know that some of those patients truly do have a low ejection fraction, but they have measurement error. They've had an ejection fraction measured higher than it really is. On the other hand, some of these patients will really have HFnEF, that they have had their ejection fraction measured lower than it really is. So I think this zone of uncertainty, the HFmREF group, should remain for some quite considerable time. We should not be in great haste to change too soon. Just a brief words about the epidemiology of HFpEF. First of all, it's very common. Probably most older people with cardiovascular disease have HFpEF. One of the things that we've noticed is that most people with cardiovascular disease will receive loop diuretics for years before they die. And indeed, in the UK, the average duration between the initiation of loop diuretics, which we often think of as treatments for heart failure, but they're actually initiated on average 2 years before the diagnosis is made, usually by family doctors and usually without any investigation. So we're interested in that group of patients. I think HFpEF is often unrecognized because the symptoms and signs are not specific. They're often attributed to old age. being unfit, obesity, or other medical conditions. You can imagine that, if you carry two 20-kilogram cases or two 10-kilogram cases up 3 flights of stairs, many of us would be breathless after that. So carrying extra weight can cause symptoms, but many of those patients will actually have evidence of cardiac dysfunction and I would say have heart failure. And it's quite hard to distinguish the effects of obesity from the effects of cardiac dysfunction in terms of symptoms. As I've said, many of these patients are treated with diuretics without further investigation, and this is something that I think we need to deal with quite urgently, because these patients have a bad prognosis, actually much worse than patients with who have features of HFpEF but who are not receiving loop diuretics. Compared with HFrEF, they're more often women, they're older by a decade on average, they have a higher body mass index and a higher systolic blood pressure. These are the common causes, and one of the reasons why it's appropriate to talk about HFpEF in a conference on metabolic syndromes. Common causes of HFpEF are hypertension, atrial fibrillation, and ischemic heart disease, but also patients who have renal dysfunction, diabetes, or obesity. It's also important to recognize that even when HFpEF is present, it might not be the main cause of symptoms. And in fact, being unfit, obese, having lung disease or joint disease may all contribute to the patient's symptoms, and HFpEF may be the comorbidity of these problems rather than these problems being the comorbidity of HFpEF. This is an analysis from Glasgow. You can see that of 200,000 people with cardiovascular disease, adults with cardiovascular disease in Glasgow, that almost 20% of them had heart failure or were treated with a loop diuretic. But notice the majority of these patients were treated with loop diuretics but had no diagnosis of heart failure. I should say that when we looked at mortality, the diagnosis of heart failure really didn't give much of an indication of an increased risk. What carried the big increase in risk was treatment with loop diuretics. So if you have a diagnosis of heart failure, but you aren't congested, you don't require loop diuretics, these patients really just have a very similar background risk to anybody else with cardiovascular diseases such as hypertension or a prior myocardial infarction. It's loop diuretics that really tell us that the patient's in trouble. And looking at these patients, it does look as though they're predominantly HFpEF. You can see that there were some people with low ejection fractions in the blue colors here, but it is really left atrial dilatation, which is common across the board of patients with ischemic heart disease, but particularly these patients who are taking loop diuretics. How should we diagnose HFpEF? I think that we need to move away from using symptoms and signs to diagnose heart failure. First of all, they're very late. Well, signs are certainly a late manifestation of heart failure. Symptoms and signs are non-specific, and I think they just lead to a lot of confusion and delay in diagnosis. And I think this is one of the reasons we commonly see patients treated with loop diuretics for years before the diagnosis of heart failure is made, basically because the loop diuretics have taken the symptoms away. Remember that loop diuretics have a class 1 indication for the treatment of symptoms and signs of congestion, so if you see anybody with a loop diuretic, they need to be investigated. We have many phenotypes of heart failure, but what we're now looking for to make sure that it's heart failure and not just cardiac dysfunction is evidence of congestion. And the thing that really helps us here is the NT-proBNP, so raised NT-proBNP, and then you want to confirm that with an echocardiogram and demonstrate left atrial dilatation. So the diagnostic steps are, first of all, think. Is the patient at risk because they have age, cardiovascular disease, or loop diuretic? They may have symptoms and signs, but I don't think you should rely too much on symptoms and signs. If the natriuretic peptide is elevated, then personally, I don't think this is enough to diagnose heart failure. I think it just raises the possibility that they are congested. I think you then need to do an echocardiogram, and if they have a raised atrial volume, combined with cardiac dysfunction and congestion, you now have the diagnosis of heart failure. Symptoms and signs, I think, are a late manifestation, and you're too late if you're waiting for symptoms and signs for diagnosis. When it comes to prognosis, the biomarkers are also very helpful. You can see in this analysis from the EMPEROR-Preserve study that the top predictors of prognosis were NT-proBNP and troponin, and really there was a very small contribution from other risk factors in this model. And you can see that if you have both an elevated troponin and an elevated NT-proBNP, then you're at high risk. And these high-risk patients might be the patients that you consider that it's worthwhile thinking about in terms of trying to improve their prognosis. You can't fix what's not broken. If the patient has a good outcome, do they need your treatment? It's just another pill they have to take. From a patient's perspective, I think there are two issues. One is quality of life, and the other one is prognosis. Quality of life in the HFpEF population is variable. It's actually fairly good for most patients for much of the time, but it is poor for some, and it does seem to be that the obese HFpEF patients have a particularly poor quality of life, and we have seen some recent successes there. Quality of life is important of itself, but it is also a useful guide to prognosis. If the patient feels well, but they have features of HFpEF, then it's likely that their outcome is going to be pretty good, and perhaps you should monitor the patient rather than jumping in with additional therapy. And we can argue that quality of life is the most important therapeutic target in HFpEF. Quality of life is the thing that leads to disability and loss of independence. The prognosis of HFpEF is actually pretty good, provided congestion is controlled. Once the features of congestion appear, if they're difficult to control or the patient gets recurrent episodes of decompensation, then the prognosis is poor, regardless of the left ventricular ejection fraction. Ejection fraction is actually not a great marker of prognosis in patients with decompensated heart failure. So just a generic comment about clinical trials. Why do we do clinical trials? Well, if you're a clinical trialist or you're a guideline maker or you're a regulator, then you do a clinical trial to show whether an intervention has an effect. And these outcomes are crafted by trialists to prove that the intervention works, and they are the basis of guidelines. But on the other hand, you could argue that a clinical trial is to show that an intervention benefits patients, and that's different. The outcomes have to be important to patients, and they are the basis of good clinical practice. And these are not necessarily the same. Looking at the therapeutic goal, we've achieved these in HFpEF. We have really no conclusive evidence for mortality, but I'll discuss that a little bit more in a moment. All-cause hospitalization, well, we've got no conclusive evidence of that either. Hospitalization for heart failure, well, we do have some evidence of some small benefits of uncertain clinical importance. Remember that hospitalization for heart failure is a sort of short-term morbidity. It's inconvenient for patients. It carries costs. But is it as important as the clinical trialists say it is? And I'm not so sure. Symptoms and quality of life, if these are poor, this reflects chronic disability and loss of independence. And yes, we have evidence of meaningful benefits from our treatments for HFpEF, at least for those with more severe symptoms. This is not an analysis of a HFpEF study because I don't have access to the relevant data, but I think it would be very similar for a HFpEF population. This is a trial called COMET. Showed that carvedilol was somewhat better than metoprolol as a beta blocker for HFrEF. But what we've done here is looked at the notional days lost due to poor quality of life, death, hospitalization, or the need for intensification of loop diuretic therapy. And I should say that hospitalization, in terms of its impact on quality of life, was treated the same as death, i.e. you had a complete loss of quality of life. The only advantage being that hospitalization is reversible and death is not. So you can see over the first year of follow-up, many of these patients actually felt pretty well. And the big loss in terms of the quality adjusted life year, as it were, was poor quality of life. If we look at 2 years of follow-up, you can see that still a lot of the days lived are lived well. Mortality has increased. Quality of life is still the biggest chunk in terms of the adverse outcome of the patients. And you can follow that up for 3 and 4 years. What you find is that many of those patients with a poor quality of life are dying, so the segment of death increases. The number of patients who were feeling well tend to deteriorate and they move into the poor quality of life group. But nowhere in the patient's journey does hospitalization have a major impact on the overall loss of quality of life, nor is there a huge impact for intensification of medication. So it is how the patient feels and are they alive or dead. Those are the big components. So what is the most successful trial of HFpEF so far? It's a trial that some of you might have heard of, but the heart failure community tends to ignore, and that is HIVIT. So HIVIT was a trial of indapamide and perindopril for elderly hypertensives. It's done by hypertension doctors who, with all due respect, are not very good at diagnosing heart failure. I don't think any of us in 2008 were very good at diagnosing heart failure, but I'm sure there was a bundle of HFpEF. Right? Probably most of the patients in this trial had HFpEF, just it wasn't diagnosed. And you can see with the combination of indapamide, and I think this would apply probably to any thiazide type diuretic, plus an ACE inhibitor, you had a reduction in strokes, you had a reduction in all-cause and cardiovascular mortality, you had reductions in heart failure, striking reductions. You can see almost a 2/3 reduction in the risk of heart failure, so highly significant. So we shouldn't forget that, and one of the important reasons for not forgetting that is that all of the treatments that we've looked at since have really been based on a background of diuretic and ACE inhibitor. So with this large improvement from these two older treatments, it's perhaps been hard to show additional benefits. So that's one of the problems with treatment for heart failure, is that existing treatment is rather effective for many patients, including hypertension, more recently obesity, iron deficiency anemia, atrial fibrillation, and perhaps chronic kidney disease. So it's hard to find treatments that are more effective than the above until the patient runs into trouble, starts developing congestion, and then we're really lacking trials that are focused on that population and showing that we can benefit. This is an overview of some of the newer therapeutic agents for heart failure. You can see that for the HFmrEF group, the story sounds rather like HFrEF, and there's a benefit from all of these agents for primary outcome, which is heart failure, hospitalization, or cardiovascular mortality. Perhaps some benefit for the HFnEF group, ejection fraction above 50%. But when it comes to a hard outcome like cardiovascular death, you can see there's really very little evidence of a benefit from these treatments for HFnEF. I do need to warn you that the hazard ratio is a measure of relative benefit. and it's very dependent on the control group event rate. So whenever you're looking at an analysis like this, the first question you should ask is, what is the event rate in the control group? Because a really striking hazard ratio of 0.5, so a 50% reduction in events. But if the background event rate is only 1% per year, you might not be very interested if only 1 in every 200 patients treated for a year is going to get some sort of benefit. And also remember that p-values are not a measure of the size of effect. They're just a question of how much confidence you are that an effect has occurred, and it's the absolute treatment effect that matters. Should also remind you that all contemporary trials only apply to patients with an elevated NT-proBNP, so they've got the beginnings of congestion. And if you can't measure NT-proBNP for some reason, then I question whether you should be using any of these newer treatments. They are more expensive than NT-proBNP, and basically I'm not sure that they have much to offer if you don't have an elevated NT-proBNP. What about guidelines for management? These are the ESC 2021 and ACC 2022 guidelines, and you can see that for HEF-MREF, they're pretty similar to the HEF-REF guidelines in recommending this constellation of treatment. Notice in all of the guidelines that diuretics have a class 1 indication for the treatment of symptoms and signs of congestion. If you don't have symptoms and signs of congestion, your prognosis is pretty good, and I don't think these treatments are going to make a difference. What about HEF-NEF? You can see these are the 2021 and 22 guidelines. There was some new information that came out between these two guidelines. There is an ESC update, really one of the cornerstones of the management of HFpEF. Think about using thiazides, ACE inhibitors and spironolactone for hypertension. Substitute the thiazide with a loop diuretic if symptoms and signs of congestion appear. GLP-1 receptor agonists for the obese patients. We haven't had time to talk about iron deficiency anemia, but IV iron and probably oral iron, but IV iron works much more quickly for the HFpEF with iron deficiency. For the patients with an EGFR less than 45, there is now evidence that SGLT2 inhibitors can delay progression of the renal dysfunction, so consider that. And for congestion, we have loop diuretics, but we also have spironolactone and SGLT2 inhibitors. For HEF-NEF, try and down titrate and potentially stop the beta blockers, control atrial fibrillation with digoxin. I would reserve ARNI and SGLT2 inhibitors for treating more troublesome symptoms. And I'm not really sure what the role of finerenone is going to be. So